Vivekananda sir is joining.
Yes, sir. Yes, sir. Rajgopal sir is also joining.
Good evening to all.
Good evening,
Good
sir.
evening, Vivek sir. Good evening, sir.
மூஞ்சியத்தான் காட்டுங்க.
I am moving to Tichur. So,
Tichur.
Rajgopal sir, good evening, sir.
I will be in train. I will call you.
Good evening. I just today that Delhi chapter
Scope
that one is
program.
scope going on.
Yes,
One
sir.
of our candidate is also there. So
Okay, sir.
there is also a delay. I think that's why Ajay Khanna is also is there in that.
Sir, he called up, sir, some time back. He just called.
There is a
up, sir.
delay. Program is
Yes, sir.
getting delayed.
Yes, sir. Yes, sir.
Anyway, first case I'm there full. Okay.
Okay,
Right.
sir. Okay. Thank you, sir. Thank you. Good evening, friends. We warmly welcome you for today's program at another PG Clinics. And we are happy to have eminent faculty from our regular scientific committee, Professor Rajgopal sir, Srinivasan sir, Vivek sir, and other senior faculty, Dr. Guru Shantapa sir. And we have three invited faculties for the day. One is Professor Madhu, Professor of Surgery from Mysore Medical College, Mysore.
Madhu, namaskara.
Sir, namaskara, sir. Namaskara.
And then we have Professor K. Karunakaran, sir, Professor of Surgery from Government Medical College, Sivagangai, Senior Professor from Sivagangai Medical College. And we have Professor Anand Mishra, sir, shortly joining us for the... we requested being endocrine case, we thought we will have them. And with that, I warmly welcome the postgraduates. One is Dr. Meghna Shetty. She is a resident from KIMS Hubli, from Professor Gurusham Tapasha's unit. She will be talking to us on thyroid nodule. The other candidate is Dr. Sweeti Kumari. Sweeti Kumari is from Banaras University, from Khanna sir's department. So with that, let us have the Guru Shantapa sir. I think once Anand Mishra sir comes, we will have the thyroid. So I will go with the abdomen case first, sir.
Good evening, sir. I am there.
Oh, welcome, sir. Welcome, sir. I thought, thank you. That is iPhone.
Sir, what happened? Why cap?
It was some family thing, sir.
Okay, sir.
Yeah.
Thank you, sir. I could not see you because you logged in as iPhone, sir. No problem, sir.
Yeah.
Then we will have the thyroid case first, having the comfort of having you.
Yeah,
so
no issue.
I think we will have Dr. Meghna Shetty, so that by then Khanna sir also come for his case. So Dr. Meghna, please switch on your video. Get the PowerPoint up on the screen. Can we have you on the video, ma?
Yes.
Yeah. So you can introduce yourself, you are head of the department, and then start the presentation. Make it full screen, Dr. Meghna.
Yes, sir. Is my PowerPoint visible, sir?
Yeah, you are good to go, Khanna. All the best wishes. Go ahead.
Yeah, thank you, sir. Good evening, professors. I'm Dr. Meghna Shetty, postgraduate, Department of General Surgery, KIMS Hubli. Today, I'll be presenting a case of thyroid swelling under the mentorship of Dr. Gurushantapa Yalagachin, professor and head of the department, Department of General Surgery, KIMS Hubli. Presenting to you the case of Mrs. X, a 65-year-old lady who's a homemaker by occupation and who hails from Sutagatti, Hubli. She presented to us with the chief complaints of history of swelling in front of the neck since 6 months. Patient was apparently normal 6 months back when it was brought to her notice by her family members that there was a swelling in front of the neck on the left side, following which the patient became aware of the swelling. Initially, it was small in size, about 1 into 1 centimeters, and over the period of 6 months, it gradually progressed to attain its current size of about 3 into 3 centimeters. There is no history of pain over the swelling, no history of recent or rapid increase in the size of the swelling, no history of breathing, no history of discomfort while swallowing, no history of change in voice, no history of loss of weight, anxiety, tremors, diarrhea, increased sweating or heat intolerance, no history of breathlessness or chest pain, no history of weight gain, constipation, lethargy or cold intolerance, no history of hair loss or dryness of skin, No history of cough, hematitis, or bony pain. Coming to her past history, she is not known to have any medical comorbidities. No history of radiation therapy received in the past. Patient was tubectomized 30 years ago. There is no history of malignancy in female first-degree relatives of this patient. She consumes a vegetarian diet. Her appetite is good. Her sleep is undisturbed. Her bowel and bladder habits are normal and regular. And she doesn't have history of any substance abuse. She attained menarche at 12 years of age. She did not have any menstrual irregularities. She attained menopause 20 years ago. She's a para 4 leaving 4 and she's had full-term normal vaginal deliveries. Summarizing my history, a 65-year-old lady presented with history of painless swelling in front of the neck since 6 months, which was initially small in size and has gradually progressed to its current size of about 3 into 3 centimeters with no symptoms of local compression, hypothyroidism, hyperthyroidism, or distant metastasis.
Okay, Meghna.
Yes.
My suggestion will be that in history, patient tells us about specifically about the size of the swelling, 1 into 1 centimeter, and then 3 into 3
So the
centimeter.
patient quantified it with the fingers, like hand movements. So like initially
Yeah,
it was
that's
small
what,
and then.
yeah, that's what I was trying to suggest you. Yeah.
Yes.
So you should not quantify this, whatever patient is saying. You should tell history in the patient's word, not in
Yes.
terms of exactly say 1 into 1 centimeter.
Yes.
If you say 1 into 1 centimeter, no, it's very specific.
Yes. Yes.
Can I ask a question?
Listeners,
Yes.
yeah.
Meghana,
Yes, sir.
just show the first slide. There's nothing wrong in that, but just to highlight that this age, sex, occupation, address is for our checklist. You could straight away written there.
Yes.
XYZ is not required. 65-year-old female. That's enough.
Yes.
Is it clear?
Yes.
We don't want to mention the name of the patient. That is fine.
Yes.
65-year-old female patient. Homemaker is fine. Why do you want to know the occupation of the patient? It
So
looks simple question, but sometimes we ask in a PG exam, female patient. Yes. Pick.
if the patient is having radiational exposure at the occupation site, then in the longer duration, she could be developing.
Basically, I wanted you to say that a teaching profession. Is it clear to you? Singing profession. Especially, we are dealing with the thyroidectomy, correct?
Yes.
Right?
Yes.
So very, very important. As a profession is concerned, as far as your case is concerned,
yes,
you need to say, because you should be extremely careful, and you know the compensation part of it and that thing. Next slide. Show the next slide. Yeah, that's okay. Next slide. I think next. Yeah, what you mentioned that swelling in front of the neck on the left side means what? What I think, what is the meaning of that word? Front of the neck on the left side, or front and left side of the neck, or it's only left side?
Sir, I wanted to like highlight that it's not exactly in the midline, sir. I like.
See, the purpose is very simple. If somebody says here in the region of thyroid and left, it can be a thyroid swelling and a lymph node or whatever.
Yes.
I think what you want to convey, I suppose, that it is on the left side, correct? More than.
Yes.
Is that the one you want to say?
Yes, sir. More towards the left side.
In the thyroid diseases of 6 months duration, pain should come last. Can you tell me few painful swellings in the thyroid gland?
Some thyroiditis.
Yes.
And then if there is a hemorrhage into a cyst or a nodule, and then transformation into malignancy, sir, can be painful.
Very, pain is not at all an important feature in this type of situation. Yes. So don't make the pain should not come first here. Yes, we say insidious onset. Then you are written about the increase in the size. What is the difference between rapid increase and sudden increase? What is the difference between rapid increase and sudden increase?
Rapid increase would indicate more towards malignant nodules, whereas sudden will be hemorrhage into the
So that
other
is the time they may complain to you about that difficulty in swallowing or whatever, etc. Change in voice and other things.
Yes.
What is the cause for change in voice? Why did you ask that?
So if there is any compression or involvement of the recurrent laryngeal nerves, hoarseness of the voice is what I wanted to.
No, don't say compression. It's even a large goiter rarely. So best to say infiltration. Okay.
Yes.
Best.
Yes.
No, even a small carcinomas infiltrate. Right.
Yes.
That's all.
Yes.
So please, other examiners, please.
Yeah, next slide, Meghna.
Yes, sir.
So why do you want to take history of breathlessness and chest pain? First is okay.
Sir, breathlessness, I would like to take it for two situations, sir. First is in case of if the patient is having secondary thyrotoxicosis, then because of the cardiovascular manifestation, a patient can have breathlessness, dyspnea, and chest pain. Another reason is if it is a malignant swelling, then the patient can have parenchymal or pleural deposits in the lung, and that can present with breathlessness.
Okay, accepted.
Sir, just sir, one minute, sir. Meghana.
Yes, sir.
Yeah.
I can't say you are wrong when you have written there cough, hemoptysis, etc. But please remember,
yes,
every disease has got certain behavior. Behavior means progress or whatever, natural course. Okay.
Yes, sir. Yes, sir.
We appreciate if you say that maybe in the breast case or maybe in the colon, but you know, in a thyroid malignancies, to patient presenting as hemoptysis and all, no, it's
Yes.
very, so it is not really required. The important points are rapid increase, sudden increase, and I would have appreciated if you say no other swellings in the neck. No other means for lymph nodal swelling.
Yes.
Is it clear?
Yes.
Right? Okay.
Yes.
Yeah. Madhu, sir, Keli questions.
Yes, sir. Meghana.
Yes. Good evening, sir.
So the sir told the cough and hemoptysis is not necessary.
Yes, sir.
The common thing like you should rule out the other swellings like lymph nodes in the neck.
Yes.
That is important.
Yes.
Bony pain you can ask, I think. Bony pain is important.
Yes.
Other than that, you have covered everything, I think. Okay, sir.
Sir and Karnakaran sir, do you have any questions or comments?
I'll ask later, sir.
Okay, Sahai sir, welcome, sir.
Sir, good evening, sir. Good evening, everyone, sir.
Meghna, I think you please go ahead with the second part of your presentation.
Yes, sir. Coming to general physical examination.
No, just Meghna. Family history. Can you go back and for the family history slide?
Yes, sir.
Now, why do you want to have a specific history in female first degree relatives?
So
Malignancy?
Yes, sir. Because here I was trying to because thyroid malignancies can be associated with malignancies of other secretory organs in females like breast, endometrium, and ovarian carcinomas, sir. So that is why I have elicited the history of any malignancy in the female first degree relatives.
Which syndrome you are talking?
Cowden syndrome, sir.
And you can't see thyroid swellings in families?
We can, sir. We can. Familial thyroid swellings also occur. There can be familial non-medullary thyroid carcinomas as well as medullary thyroid carcinomas, which more commonly run in families.
So your family history should be you are more interested in familial thyroid cancers first thing.
Yes.
Then you go for the rare cancers.
Yes.
Yes.
Yeah. And Meghana, don't take it for. See, the endemic goiters can also run in family, na? Endemic goiter.
Yes.
You have 3 siblings using that same, so that also to keep it in mind as far as thyroid is concerned. Okay.
Yes. Yes.
Remember, every swelling, don't think in that direction of malignancy only when we talk about the family history. Is it clear?
Yes, sir.
If you have a tuberculosis patient family history, you can have patients, brothers and all also having tuberculosis, correct?
Yes. Yes, sir.
Yes. And
Yes.
I just want to make one comment on your next slide, show that diagnose something next here. Best would have been to say that at the end of that, whatever small inside that last word, distant metastasis, that is not required. Is it clear to you?
Yes, sir.
One, just as far as this is concerned, I will consider as a non-toxic. That word should come. Probably non-malignant thyroid swelling.
Yes, sir.
Right.
Yes, sir.
Yes, please go ahead.
Coming to general physical examination, here is the elderly lady, moderately built and nourished. Her pulse rate was 76 beats per minute. Her blood pressure was 120 by 80 millimeter of mercury. Her respiratory rate was 16 cycles per minute. She was afebrile. Her BMI is 21.64 kg per meter square. Her Karnofsky performance scale is 90. Patient did not have pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Coming to examination of neck, on inspection, a solitary oval swelling of size 3 into 2 centimeters noted in the anterior aspect of the left side of the neck with its lower border about 3 centimeters above the left sternoclavicular joint and upper border extending up to the thyroid cartilage. The swelling has smooth surface with well-defined margins. The swelling moves with deglutition and its inferior border is visualized on deglutition. The skin over the swelling appears normal. No dilated veins noted over the neck and upper chest. Trachea appears central. No other swellings were noted in the neck. So this is the image of the swelling, sir. And I have a small video to show its movement with deglutition. Coming to palpation, a solitary ovoid-shaped swelling in left anterior aspect of the neck, measuring 3 into 2 centimeters. Its medial border is at 1 centimeter from the midline, laterally extending till anterior border of left sternocleidomastoid muscle, superiorly up to the upper border of the thyroid cartilage, and inferiorly 3 centimeters above the left sternoclavicular joint. Its surface is smooth. It is hard in consistency, regular and well-defined margins. Rest of the thyroid gland is not palpable. Trachea is confirmed to be central in position. Carotid pulsations felt bilaterally at their normal position. No other palpable swellings in the neck. On percussion, there was a resonant note heard over the sternum. Auscultation, no bruit heard over the swelling. Systemic examination of the cardiovascular system was within normal limits. First and second heart sounds were heard and there were no murmurs. Respiratory system, bilateral normal vesicular breath sounds heard, no added sounds. Abdomen was soft, non-tender and no palpable organomegaly. Shall I summarize the history, sir? History and examination.
Go ahead.
A 65-year-old lady presented with history of painless swelling in front of the neck since 6 months, which was small in size and gradually progressed to its current size of 3 into 2 centimeters with no symptoms of local compression, hypothyroidism or hyperthyroidism. On examination, a solitary swelling in left anterior aspect of neck, which moves with deglutition, smooth surface with well-defined regular borders, hard in consistency with no palpable lymph nodes in the neck. I would like to come to a diagnosis of this being a solitary nodule of left lobe of thyroid in euthyroid state.
Edna, would you go back to general examination?
Yes, sir.
Yes. Why you have mentioned about BMI? What is the significance here? Am I audible?
Yes, sir, you're audible, sir. But this reflects the general nutritional status of the patient, sir, the BMI.
Nutritional status of the patient.
Yes, sir.
Does it make any sense in this thyroid?
Sir, I would like my patient to be with the optimal nutritional level if I'm offering a form of treatment like.
case of hyperthyroidism,
Otherwise, say for thyroid, it doesn't.
in case of hyperthyroidism and all,
Yes, sir.
what you may get?
So there will be weight loss, sir. So the BMI will be on the lower side, sir.
Yeah. The reverse happens in case of hypo. Am I right?
Hypothyroid. Yes, sir.
Okay, I'll come to the next point. Karnofsky scale. Why do you say it's 90? What is the significance of saying about this Karnofsky scale?
This means this Karnofsky scale score being 90 indicates that the patient is able to carry out her day-to-day activities without much symptoms of the disease.
No, what is the significance here? Why you are mentioning here? What do you want to?
Sir, I want to again highlight on the general status of the patient, sir, and like I am still keeping a possibility of malignancy. So when we discuss about malignancies, we have to also highlight on the general performance status of the patient. So as so far I have not ruled out malignancy completely, so that is why I've kept that in.
See, this kind of patients with scores 70, 80 or 90 or 100, we can perform radical treatment and all. The patient can withstand such treatments. Am I right?
Yes, sir.
Now, what is Karnofsky zero?
The patient is not alive, sir.
Good. What is any other scaling for this performance?
Yes, sir. Eastern Cooperative Oncology Group.
What zero means?
Sorry, sir.
ECOG zero means what?
ECOG zero.
Okay, it is reverse. It is 100 in case of Karnofsky.
Yes.
0 in case of ECOG.
Yes.
The patient is perfectly all right.
Yes.
Sir, can I ask one question now, Meghana?
Yes, sir.
In a malignancy, which one you prefer?
Like in thyroid malignancy, sir?
Okay, in general, let us say carcinoma stomach patient is there.
Yes, sir.
Carcinoma colon is there.
Yes, sir.
Which one you prefer? Just to know how the concept of ECOG came. Yes.
Sir, if given an option between stomach and colon, sir, and thyroid, I would prefer thyroids.
And not that way. What I want to ask a question is that usually ECOG came up because these are the patients whether they can withstand chemotherapy. It is not just surgery. Is it clear?
Yes.
So multimodality treatment has come now, correct?
Yes.
So it is not just surgery, radiotherapy, chemotherapy. So because of all these things, that new ECOG came. That's just to keep you informed. Yes.
Yes.
You just said that you are keeping a possibility of malignancy in this case.
Yes, sir.
Now you say your diagnosis is left side solitary thyroid nodule. Because of what reasons you think it is a malignant?
So first of all, my patient is a female. So thyroid malignancies are more common in females. Then next, coming to her age group, she is 65-year-old, which is by which I infer that she belongs to the elderly population, and thyroid malignancies in younger patients as well as in elder patients. And then it's a 6 months swelling of for a lesser duration, 6 months, which is increasing in size, and also the examination finding the consistency being hard. So that these factors made me think that it could be malignancy, sir.
Meghna, this is Dr. Sahai. What is thyroid paradox?
So thyroid paradox is it's a phenomenon seen in papillary carcinoma thyroid, wherein highly cellular tumors are soft to palpate, whereas tensely cystic tumors will be hard to palpate, sir.
Is it only for papillary tumors?
Usually seen in papillary carcinoma of thyroid, sir.
Okay. You said sternal percussion.
Yes.
Sternal percussion is usually, what do you expect to do? Why did you do a sternal percussion here?
So here I did it for two reasons, sir. One was to see if there was there any retrosternal extension of this swelling, but I had already ruled out because the lower border of the swelling was well made out on inspection and palpation. And also, if this were to be a malignancy, then if there were mediastinal lymph nodes because of the metastatic spread, then even that could give a dull node, sir. So keeping that in mind, I had done sternal percussion.
Well, ideally, it's not done. It doesn't give you any information.
Yes.
And mediastinal lymph nodes is, without a cervical lymph node, getting mediastinal lymph nodes is a bit far-fetched, isn't it?
Yes, sir. Yes.
I have one or two small query, Dr. Meghna.
Yes.
You mentioned, what is that? Papillary carcinoma feels softer. What did you say?
So the thyroid paradox, which is more commonly seen in papillary carcinoma thyroid. Yes, sir. Where highly cellular tumors are. Yes.
I agree it is cellular. Just don't get confused with two things. Papillary carcinomatous nodule need not be soft, but we say the lymph nodes can be soft.
Yes.
Why?
Necrosis or degeneration.
It is because the papillae are so thin, they are known for some amount of bleeding. That is one of the reasons they are a little bit bluish in color, as well as some kind of a consistency soft. I agree, rapidly growing tumors can definitely have, but that, I think that impression you should not have. Tomorrow say that somebody with a solitary nodule which is soft, it can papillary.
It is papillary. It shouldn't. It is just any nodule.
Yes.
So that's just a clarification. So
yes.
It's not that we can't get. I just want to show that inspection slide. Just small minor change, maybe the language. No. Yeah, just hold on.
Yes.
I just wanted to tell you anterior aspect of the neck. What do you mean by anterior aspect and posterior aspect? So what did you wanted to say? Probably anterior triangle. Is it correct or posterior triangle?
Yes.
What do you wanted to say? Please tell me.
Sir, yes, sir. I should have specified it as to be anterior triangle of the neck.
So what I am trying to tell is, in the here there is oval swelling noted in the anterior triangle in the region of thyroid. You can always say now. Okay.
Yes. Yes.
In the region. Once it moves with the deglutition, then straight forwards you can say thyroid swelling is visible, whatever. But
other statement can be, sir, lower part of neck anteriorly.
Yeah, that is fine. No problem.
Okay.
Yes. And one more small point here is, suppose pulsations are noted over the swelling. What is your interpretation? May not be important in your case, but you only written dilated vein there. If you find pulsations, what are two interpretations?
Vascular swelling.
No, be specific to the thyroid. Come, say the diagnosis. That means, yes,
Graves' disease.
One is possibility. The another is sometimes node can be anterior to the carotid artery. Even it can give a transmitted pulsation. You need to know that.
Yes.
Okay. Yes. Sometimes a node, it can be anterior to that. So that's what is important here. Yes. Next. My question to you at this stage is, before you make a solitary nodule as diagnosis, how did you rule out any nodules on the other side of the neck? What I mean to say is the right lobe. It's a very common postgraduate question.
Sir, I have palpated the other side of the gland also, the right lobe of the
thyroid. I wanted to ask you any special method you did. That is where the importance will come now.
So this nodule being only 3 into 3 centimeters, sir, the method I used to palpate this nodule was Kreil's method, sir. I stood in front of the patient, and with my left hand, I stabilized the patient's head, and with the palp of my right thumb, I have palpated for the swelling when the patient was asked to, when the patient was instructed to carry out the activity of deglutition.
No.
Similarly, other lobe.
Just a minute.
Yes.
About this left side nodule, there is no confusion, madam.
Yes.
What to say? I agree with you. You said right lobe is normal. I want you to say I have done Lahir's method. That is simple. Just if examiner asks you, why do you say right lobe is also normal? Right lobe not at all enlarged. So you can just push it and see whether any lobe is enlarged or a nodule.
Yes.
That is what is expected from here.
Yes.
That's all, sir, from my side.
Anand sir?
Yeah. Go ahead to the diagnosis, Meghna.
Yes, sir.
So your diagnosis
I've made
is
solitary nodule of left lobe of thyroid in euthyroid state, sir.
so anything missing? You were saying that you think it is a malignancy. Anything missing? So thyroid has 3 components in the diagnosis.
Yes. Yes.
One is you have solitary nodule. It is solitary or multinodular goiter or diffuse swelling.
Yes.
Morphology of the gland. That's
Yes.
one component.
Yes.
Okay.
Yes.
The other thing is same way. If it is one side, then I mean it is morphology. If it is solitary, then you have to specify which side.
Yes.
So solitary nodule, left lobe, it becomes morphology of the gland.
Yes.
Okay. The second component is the functional component. Whether
Yes.
patient is euthyroid, hypothyroid, or hyperthyroid. This is clinically. Okay.
Yes. Yes.
So that comes into the. Now third component comes pathology or nature of the disease. It should come. Whether you are thinking it is a benign, or whether you are thinking it is what is the pathology you are thinking. Okay.
Yes. Yes, sir.
So you said that you think it is a malignant because of these reasons, but it is missing in the diagnosis. Okay.
Yes. Yes.
And then other components which are there, you should mention once they are present, whether it is retrosternal extension. Patient has if retrosternal extension on examination, then it will come.
Okay.
In all other diagnosis, it will not. You will not mention when there is no retrosternal extension. If
Yes.
associated cervical lymph nodes are present, you have to mention cervical lymphadenopathy, which side, what are the level of lymph nodes clinically.
Yes.
So that becomes clinical diagnosis. Okay.
Yes.
So would you like to? So nature has to come. Whether you think it is benign or possibly malignant, it has to come into the diagnosis. So will you like to qualify revise your diagnosis?
Yes, sir. This is a solitary nodule of left lobe of thyroid in euthyroid state, probably a malignant one.
Okay, now it is complete. And
Yes.
you have explained the why do you think it is malignant?
Yes.
Okay.
Yes.
Okay. On history, can you tell when you will have the suspicion? You told that one is the age,
Yes,
other
sir.
is the rapidity.
Yes.
Huh?
Yes.
Any other thing in the history?
So the rapidity, associated pain, sir, and then there are the symptoms such as hoarseness of voice, or there is difficulty in swallowing. So these indicate that
Yeah.
it could be.
And then on examination, other features of malignancy?
So
When you-
along with the swelling being hard in consistency, if it is immobile and fixed to the surroundings structures, then the possibility of malignancy should be thought of, sir.
Yes, that's okay. Another thing is even if swelling is very mobile, but patient has a
Hello, sir.
Doctor, yeah, I think Dr. Meghana,
Yes, sir.
sir is trying to tell you
Yes, sir.
how seriously you think your case is malignancy. Just want to ask you, what are the points are there in your entire history to hear?
The first one, considering the sex of the patient, sir.
No, please remember, you just have to remember that thyroid diseases are more common in women. That's all.
Yes, sir.
If I ask you a question, 100 men have got solid nodules, 100 women have got solid nodules.
The likelihood of malignancy is more.
Men having is more.
Yes.
So, see, try to understand the difference. Understand?
Yes.
We tell femoral hernia is more common in female, but that doesn't mean femoral hernia is the commonest in females.
Yes.
Is it clear?
Yes.
So that is not the reason. Just because female, you can't say it is malignancy.
Yes.
Next. What is the sex?
The age of the patient, sir. She's 65-year-old.
In 65 years of, just a minute, 65 years of age, which malignancy of thyroid can get? Thyroid is notorious for all age, no problem about age. Young also, middle age also, old age also. Which one?
Sir, elderly age group, I would like to consider medullary carcinoma. Commonest is medullary, sir, in this age group.
Commonest is medullary.
So in this age group, it is medullary, sir. The commonest malignancy is papillary carcinoma thyroid, sir. But the presentation is at an earlier age group, they say 40 to 50 years.
So what I'm trying to tell you is that this is the age group. Yes, anaplasia is anaplastic is one possibility you would like to consider.
Yes, sir.
Okay, that is in the history wise there is no hoarseness of the voice.
Yes, sir.
No rapid increase.
Yes.
Clinical examination, only one finding. You because of that you said malignancy. What was that?
The consistency, sir. It's hard and consistent.
But it is so nicely mobile according to you. It moves freely with the deglutition.
Yes.
So, okay, now I will ask you what are the other causes for a hard thyroid swelling? One, I take it from you. Okay, let us say malignancy. I have not examined the patient. All right, one. Second, sometimes you get a nodular goiter. One area is hard, long standing. What is that due to? I gave a clue, calcification. Okay.
Calcifications, yes.
Calcification. Sometimes you get that here. Any other nodule which can be hard, rarely. Thyroiditis, which thyroiditis?
Riedl's thyroiditis.
These are the questions which you may have to get ready in the examination.
Yes, sir.
A hard nodule of a malignancy which is solid, how do you differentiate from a hard nodule because of your thyroid, so-called the paradox, what you said just now? It contains, let us say, blood clot. You may have to do a gadgets like test, hold that nodule and try to press. It is hemorrhage in a nodule. There is a possibility. These are just few points which will tell you. Lyon's method you should do here because to rule out other side nodule, because it changes your diagnosis.
Yes, sir.
Okay, that's all from my side. Please, others take over.
So tense cystic, sir was telling, so tense cystic nodule can also be just a benign swelling, cystic swelling. Tense cystic can also be, can give you a hard consistency.
Yes, yes.
Yes. So can we move on to investigations?
Yes, please.
Yeah. So Meghna, how will you manage this case?
So because the diagnosis I've made is solitary nodule of the left lobe of the thyroid in euthyroid state, probably malignant, sir. First investigation I would like to get is a thyroid function test. I would like to look at the TSH levels, sir. Because if my TSH levels are elevated, then because malignancy is one of the differential diagnoses that I'm considering, then the possibility towards that will be more. And if it is less, then I can consider it as a benign etiology. So that would be the first one, sir. Then following which, I would like to get ultrasonography of the neck, sir, to know the characteristics of this particular swelling. And in ultrasonography, I would like to differentiate this between benign and a malignant swelling. So I would like to look for the size of the swelling, the site of the swelling, so presence of any other nodules in the opposite lobe of the thyroid gland, and pertaining to this particular nodule, I would like to look at its echogenicity, sir. So, and after that, I would like to look at its consistency, whether it is solid or cystic. Following which, I would like to look at its margins, whether it is regular margins or whether it has infiltrative margins. And also, I would like to look for calcifications within this swelling. And if microcalcifications or speculated calcifications are present, then again, this being a malignant thyroid nodule, the probability of this being a malignant thyroid nodule increases. And also, I would like to see whether the dimensions of this nodule, whether it is more taller than it being wide, because then again, it would indicate that this is a malignancy. And then the general nature of the gland, whether there are other nodules seen. and later on the neck per se to look for the central compartment as well as the lateral compartment to see whether are there any lymph nodes that could be detected with USG, sir. So this would be the next investigation I would like to do.
Okay. Anything else?
After this, sir, after USG, then I would like to go for a USG guided FNAC of this swelling, sir.
Okay, that is accepted. So tell me anything else you want to you can do with the ultrasound?
So I can also look for the vascularity of this node.
Vascularity, and then you can also see shear and strain also. If you have
Elastography. Yes,
if
sir.
you have the
USG
facility,
elastography.
yes, facility with
Yes,
yours.
sir.
So tell me the features of malignant lymph nodes, if there are lymph node associated.
Sir, malignant lymph nodes, sir, they will be more, the normal lymph nodes will be oval in shape, whereas malignant lymph nodes, there will be change of shape to more rounded structure with the bulging borders, and there will be loss of echogenic hilus, sir. And they will be hypoechoic.
Hypoechoic. And cortical thickness, it will be more than 3 millimeter. I mean, cortical thickness will be very high. Yeah.
Yes. Yes.
So, okay. Dr. Shenoy, sir?
Meghana?
Yes, sir. Yes, sir.
So what type of ultrasound you will prescribe? Normal ultrasound or anything?
Doppler ultrasonography, sir, with incorporated Doppler.
Because high frequency ultra. You have to write as a high frequency ultrasound.
Yes, sir. 10 to 13 megahertz.
What's the advantage?
The vascularity can be.
So and what's the minimum node size can be picked
less
up?
Than 3 mm. Nodes less than 3 mm can also be picked up with this frequency, sir.
Cystic lesions? What's the size? Minimum size?
I'm not aware.
2 mm, less than 2 mm can be picked up by this.
Yes.
Okay.
Meghna, you said you'll use the Doppler. Why do you want to use the Doppler?
So, because one of the characteristic which differentiates a nodule from like whether it is a benign or a malignant one is that there will be increased vascularity, sir. And also there are highly like vessels in the neck like IJV and carotid artery. So I can also know whether this particular nodule is infiltrating those structures. So that is why I would like to use a simultaneous Doppler with.
Do you know what is restive index? Do you know what is restive index?
So in malignant thyroid nodules, there is high resistive index.
What do you mean by that?
That means even on, sir, I'm not aware of it, sir. I am not aware.
Right. It is the difference in flow in normal arteries, normal vessel to the abnormal vessel, the ratio of it.
Okay.
So that deletes, that's for in deletes malignancy.
Yes, sir.
Karnakaran, sir.
Sir, let her go ahead.
Madhu, sir.
So next, Meghana, how will you proceed now?
Sir, after USG guided FNAC, sir. These were the images. This was the initial ultrasound of the neck. So this is like the report of the USG guided FNAC of the swelling.
Go to previous slide, USG findings.
Yes, sir.
So,
Excuse me?
Yes, sir.
Is it done by sonologist or done by surgeon themselves?
The USG, sir.
USC guided FNAC.
So better if done by the surgeon because we will know where to put the needle to so that the optimum.
I'm asking in this case. Who has done
it was done by a sonologist, sir.
FNAC is done by?
It was done by a pathologist, sir, in the presence of a surgeon.
Okay. Go ahead.
So Meghna, what is thyroids?
So thyroid stands for thyroid image reporting and data system, sir. So this considers the sonography findings of the thyroid nodules, sir. So this has 5 components. So first one is composition of any thyroid nodule, then is its echogenicity, then its dimensions, like whether it is more taller than wider or wider than taller, then the presence of calcification, sir. So accordingly, it is graded from thyroids 1 to thyroids 5. Thyroids 1 is a benign swelling, sir, whereas
Okay, that's okay. So tell me, is it acceptable all over the world, all continents, all country, like BI-RADS?
So, American Association of Radiology, that they were the ones who proposed TRADS, sir.
But then is it my question is it acceptable to all, everybody, every country, every institution? So it is not acceptable. There is a Korean thyroids, there is an European thyroids, there is an American thyroids, and then American Thyroid Association has given a different classification. American, but the bottom line is you have to know the components of what are the features which are suspicious, which suggest malignancy on ultrasound. You should know. So they have all given their predictive value. So it's a combination of all those features which we were discussing. Okay.
Yes.
Now go to the FNAC slide.
This is the USG guided FNAC of the swelling.
Okay. Highly cellular. Okay. Can you read it?
Highly cellular smears showing hemorrhagic background with scattered oval to spindle cells in loose clusters as well as in single and vague acini. These cells show plasmacytoid appearance with eccentrically placed oval to spindle hyperchromatic nuclei with coarse chromatin and abundant eosinophilic cytoplasm with distinct cell border. Background also shows few macrophages, binucleated, multinucleated tumor giant cells with patches of pink material, amyloid, and lymphocytic special stain Congo red for amyloid was positive. Impression feature suggestive of medullary carcinoma thyroid.
Meghana?
Yes, sir.
Meghana, one question to you.
Yes, sir.
Clinically, without doing any investigation, when you can give a diagnosis of medullary carcinoma of the thyroid? If say MS exam case, lady with the solitary nodule is given to you. Tell me. Clinically. One clue.
So hypertension.
And just a little bit of clue. Anything examination. Yes. What is Sippel syndrome?
Sippel syndrome is it's also it's a name given for multiple endocrine neoplasia 2A types, sir.
What are the components?
Here, 100% of the patient diagnosed with this syndrome will have medullary thyroid cancer, and in about 50% there will be pheochromocytoma. And in about 10 to 20% there will be primary hyperparathyroidism. So, along with this, there are skin conditions called as cutaneous lichen amyloidosis, and also in some of the cases, patients can have Hirschsprung's disease, sir.
No, just hold on. See, you can't feel the abdomen for pheochromo, you can't feel parathyroid, all that different. Simple is a mucocutaneous neuromass. Okay.
It's seen in MEN 2B, sir, which is Wogenman Fobesis syndrome.
Yes. It has got medullary carcinoma component. Okay.
Yes.
So that's what I wanted the answer from you. Okay.
Yes.
See, in general, if you have a thyroid with the lymph nodes, you say papillary carcinoma in clinics.
Yes, sir. Yes.
Thyroid with a bone met, what do you say?
Follicular.
Usually follicular.
Yes.
Right? So clinically, I'm only talking about clinical. This is your reference. Yes, sir.
May I just push in a word?
Yes.
Medullary carcinoma thyroid is usually seen in the upper lobes.
Yes, sir.
It is never seen in the lower lobe. It is always seen in the upper outer lobe.
Yes.
Right? So because if you find a swelling in the lower lobe, it will never be a medullary carcinoma of the thyroid.
Yes, sir. Yes. Because
So-
medullary carcinoma arises from C cells or parafollicular cells, which are concentrated in the posterior medial
Right.
upper
Because they
posterior
come
aspect of
from the
neck.
lateral. They come from the
Yes.
posterior lateral portion to
Yes.
the neck. So
Yes.
that's why.
Yes.
So Meghna, I take further the question of Dr. Shenoy. Tell me features
Yes,
on history which can suggest a medullary thyroid cancer. Give your suspicion of medullary thyroid cancer on history. We
Again,
discussed
sir,
about
the
the
age
examination.
group of the patient. Yes, sir.
Not
The
truly,
age
not
of the
truly age
patient.
group. Not truly age group. Age group, if you
Yes.
go familial, they will be early.
Yes, sir.
Sporadic
Sporadic
can be at
cases
any
will
age.
have a presentation at around 50 to 5th to 6th decade, whereas familial, they'll have an earlier presentation depending on the type, sir.
Leave this age. Anything on history. I'm not saying on demography. History. The clue is these patients can have some plurihormonal secretion, paraneoplastic things. Can you have any symptom? Common symptom associated
Diarrhea,
with medullary?
flushing.
Yes.
Diarrhea and flushing.
So any thyroid nodule with history of diarrhea and flushing associated on history.
Yes.
So that was on
Yes.
history. Okay. That's all from my side for right now. Yeah.
Meghna,
Yes, sir.
what is amyloid?
A myeloid is a eosinophilic material, sir, that is in abundance in parafollicular cells.
I'm asking whether it is a carbohydrate, protein, fat,
It's a protein, sir.
protein.
Yes, sir.
It looks like a misnomer. Am I right?
Yes, sir.
Yes. Go ahead.
Now you have a diagnosis of medullary carcinoma thyroid. How will you proceed?
After this, like after seeing the features, sir, now I would like to know, because medullary carcinoma has both sporadic as well as familial presentation. Even though the age group of the patient is suggestive more towards a sporadic onset, I would like to rule out the familial onset of this medullary carcinoma, sir. So hence, I would like to work up to look for other components in men syndrome, sir. So, in this case, I would like to go ahead with the USG abdomen to look for any pheochromocytoma, and also calcium levels and the parathyroid hormone levels, sir. So this is for the components of the familial syndrome. And again, medullary carcinoma is known to have lymphatic spread, and it is more aggressive a disease as compared to differentiated thyroid carcinomas. I would also like to look for in USG, I had got like few subcentimetric lymph nodes. So to further see if there is other lymph node involvement, and to know for loco-regional status of the disease, I would also like to get a contrast enhanced CT of the neck and the chest, sir. And then again, it can metastasize to abdomen. So CT and USG of the abdomen to look for liver mets also I would like to get in this case, sir.
Okay, hold on. So there you need to know two components. I agree with you.
Yes, sir.
One is the disease itself, disease
Yes.
per se, spread. So you want to have a CT scan of the chest and mediastinum.
Yes.
Second thing you told me that you wanted to know whether it is sporadic and familial, and you want to rule out other components.
Yes.
So for parathyroid, I accept PTH and calcium.
Yes.
For pheochromocytoma, it is a
Sir,
biochemical. Pheochromocytoma is a biochemical diagnosis,
yes.
and then
Yes.
once you have a biochemical diagnosis, then only you go for imaging. So
Yes.
it should not be an ultrasound. It should be a 24-hour urinary
Plasma
norepinephrine
and
or
urine.
PMA.
Yes.
Okay.
Yes.
Once you have raised, then only you go for the imaging.
Yes.
Okay.
Yes.
Now tell me, if it is a sporadic, what will be the management? If it is familial, what will be the management?
So if it is sporadic, then like I would after doing the metastatic workup, If it is only a disease confined to the thyroid gland and with the lymph nodes, then I would like to offer this patient a total thyroidectomy with the central compartment lymph node dissection, as well as bilateral modified radical neck dissection, because on USG as well as CT there were nodes seen in the lateral compartment, sir.
Okay, hold on.
Yes, yes.
Do you know any biomarker, tumor marker associated with medullary thyroid cancer?
Yes, sir. Calcitonin and also carcinoembryonic antigen, sir.
So, do you want to do it before surgery, or you want
Yes,
to
before surgery as well as, yes, sir, before surgery and after surgery also, sir.
after surgery?
Yes.
Okay, so you have to do it. Ah.
Yes, sir.
And what is the significance? Why do you want to, once you have diagnosis, why do you want to have it before surgery, this tumor marker?
So that gives us the tumor burden, sir, because as the levels of these markers increase, we can also predict like what will be the tumor burden. If it is less than, if calcitonin is less than 20 picogram per ml, then we can say that the patient a total thyroidectomy with central compartment lymph node dissection would suffice. Whereas as the levels increases, even though radiologically there'll not be any evidence of metastasis into the lymph node, the possibility that the lymph nodes will be harboring an occult disease is more. So that would guide me whether a lateral compartment dissection is needed or not.
Accepted. So that's why you need to have calcitonin, because it will predict the tumor burden.
Yes.
And why do you want to have CEA?
So again, this is not exclusively produced by medullary thyroid cancer, sir. But when done as a co-marker along with calcitonin, again this predicts the tumor burden. And also, if the calcitonin levels are normal and the CEA levels are higher, then again it indicates it's an aggressive form of medullary thyroid cancer, sir.
So there is de-differentiation, more de-differentiation, and that's why they are aggressive. Okay.
Yes.
Now tell me just, yes, sir.
No, please go on. I'll ask later.
So tell me just the principles of this familial variety of medullary thyroid cancer management. Just principles.
May I ask just one question before that?
Yes.
Yeah, please.
Yes.
Meghna,
yes,
you have a patient with medullary carcinoma of the thyroid.
Yes, sir.
Can you do any test on this patient to find out whether it is sporadic or familial?
The RET gene mutation DNA analysis can
Very
be
good.
done.
What's important about it?
So if it is present, then it is familial. Then we'll have to go back and find out other family members.
No, it will be present in both, in familial and sporadic.
More aggressive. If found in familial, it is more aggressive, sir.
No. If it is found only in the cancer cells,
okay, sir.
Then it is sporadic. If it is found in all the cells,
okay, sir. Yes.
Then it's handed down by the parents. So
yes,
because it's handed down, it's found in all the cells.
Yes.
So this is how you'd find out whether it's sporadic. Or
yes.
Excuse me, sir. Can I ask one question?
Yes, please go on, sir.
Meghna, what are the types of modified neck dissection?
Modified neck dissection 1, 2, and 3, sir. In type 1, only the spinal accessory nerve is preserved, whereas in type 2, the spinal accessory nerve as well as the internal jugular vein is preserved. Modified radical neck dissection type 3 is also called as functional neck dissection, wherein the sternocleidomastoid, spinal accessory nerve as well as the internal jugular vein is preserved, sir.
I have this debatable issue regarding type 2 modified radical neck dissection. Some senior teachers or senior professors say it is preservation of the spinal accessory nerve and sternomastoid.
Okay.
There is one surgeon at MSKCC called Jatin Shah says the preservation of spinal accessory nerve and sternomastoid. What is the purpose of removing the sternomastoid if at all you preserve the spinal accessory nerve? That is his question.
Okay.
But majority of the surgeons all over the world are more in favor of preservation of spinal accessory nerve and IJV, whereas Jatin Shah's argument is, what is the purpose of preserving spinal accessory nerve when you remove the sternocleidomastoid? Apart from that, he says the nodes are more in and around the IJV then it has to be removed. That is his way of argument.
Okay,
Sir, Karunakaran sir.
Yes.
This is Dr. Gurushantapa sir. I'm at
Yes,
KIMS.
sir.
What you said just now, I don't know whether she's about to mention this. This is the same thing I tell my postgraduates also.
Okay, sir.
Even though theoretically in the textbooks mentioned the types, yeah, like exactly if accessory nerve is preserved, then the component of muscle also has to be thought of. So preserving only one of them doesn't mean anything. Same explanation I tell my postgraduates. I don't know why in the textbooks they have mentioned only jugular in the type 2 and then 3 including all muscle and the nerve.
But there is a debate going on, sir.
Exactly, sir. Exactly. Thank you, sir.
Yes, go ahead.
Yes, Meghna, tell
Yes,
me
sir.
how will you manage if it is a familial one?
So familial
Familial one means patient
Yes.
has associated pheochromocytoma also.
Yes. Yes, sir. So if patient has associated pheochromocytoma, sir, then I would like to address the pheochromocytoma first, sir. Before we offer the patient surgery for medullary thyroid carcinoma per se, we'll have to go ahead with laparoscopic, retroperitoneoscopic adrenalectomy, preferably a cortical sparing one, sir.
But patient will always ask you, I came to you for the thyroid swelling. Why are you operating my abdomen?
Because if pheochromocytoma is left intact and then we go ahead with the thyroid surgery, sir, during the surgery and while induction, during the anesthesia, because of the massive release of catecholamines, there could be catastrophic cardiovascular events that could lead to death of the patient, sir. So,
Okay.
Yes.
And then if patient is having only parathyroid and this medullary thyroid cancer, patient is not having the other component pheochromocytoma.
So
then what will be your management?
Then I would like to address the primary hyperparathyroidism along with the surgery for medullary carcinoma thyroid, sir. Usually, the gland which is enlarged, only that is removed, sir. Whereas with the preservation of the other parathyroids.
Okay, but you see usually hyperplasia in these cases. Okay, I accept that. Yeah. So please, other examiners, please.
Okay, Meghana.
Yes, sir.
Is there any difference of thyroidectomy for medullary carcinoma and let us say papillary carcinoma?
So the central compartment lymph node dissection, sir.
What is that?
Which involves removal of the lymph node.
No. What I would like to mention to you is that if you leave behind some tissue in papillary carcinoma thyroid, let us say.
Yes, sir. Yes, sir.
You have a doubt near that nerve.
Yes, sir.
How do you treat that that thyroid tissue in papillary carcinoma?
With radioactive iodine ablation, sir.
Sorry,
radioactive iodine remnant ablation, sir.
Okay, okay. You do that in medullary carcinoma thyroid. That is my question.
Yes, sir. We don't do that in medullary carcinomas are non-radioiodine avid, sir. They do not take up, they do not concentrate radioiodine. So radioactive iodine is not a treatment modality.
So that is the answer which I wanted. Is it clear?
Yes.
So it should be a total thyroidectomy. No doubt both you do total thyroidectomy, but
yes,
there should be whether it should be very carefully done not to leave any thyroid tissue. Is it clear?
Yes.
And what about the lymph nodal status in both? Let us say compare with the say papillary versus this.
Yes, sir. Sir, medullary are known for initial ipsilateral central compartment and then to the lateral compartment, sir. Whereas in papillary thyroid carcinoma, like the lateral compartment lymph node metastasis is higher. So central compartment lymph node dissection is offered along with total thyroidectomy for cases of medullary carcinoma thyroids.
So what you would like to mention is that you should be in general more aggressive for medullary carcinoma thyroid.
Yes.
Clear? in
Yes.
whichever form. There's
Yes.
no prophylactic thing for papillary now, that central line. Okay.
Yes. Yes.
So that is the only other thing important here. Now, what is it is it TSH dependent?
No, sir, it is not TSH dependent.
So then what other options you have got now? For some reason, you have removed the thyroidectomy and
Yes.
notes everything cleared, but still there is some tissue left behind, or so sometimes it happens. So it doesn't respond to radioiodine therapy. So
Yes.
any other therapy you can try in such
So,
situation.
sys-
Situations are different in each case.
systemic therapy can be offered to the patient, sir,
So
in the form of tyrosine kinase inhibitors, sir. Like tyrosine two commonly used tyrosine kinase inhibitors which are approved so far is vandatinib and cabozantinib, sir. So this can be offered to patients.
So
And,
I just want, before that, just say radiotherapy also to be considered. We know definitely that it is not the answer, but remember in medullary carcinoma thyroid, there will be some cases where you may not be able to do a complete dissection or something.
yes.
This is one thing you need to keep mentioned. That's all. And
Yes.
then of your say, I will follow it later with the
Also, yeah.
L-type therapy.
Yes.
So that's all from my side. For time is also catching. Any other, sir?
One more question, sir. Last
Yes,
one.
sir. Please.
Maina,
Yes, sir.
how do you test the family members whether they are having, oncogene or not?
So the DNA testing has to be done, sir.
Yeah, I'll tell you, there is two important things. One is 634, codon 634 and
Yes, and 918, sir. Yes, sir. 634 is more in terms of MEN 2A and 918 for MEN 2B, sir.
Yeah. These two tests are done at Tamil Nadu in Christian Medical College, Vellore. I think that it is done at SGPGI Lucknow. Anand, your response.
Yeah, it is available, sir. Yeah, it's available in Lucknow. And I think Ranbaxy and some private labs are also offering this. But cost is the issue. Yeah.
Okay. Yeah. Thank you.
Yeah. Meghna, what is prophylactic thyroidectomy?
Sir, in familial cases of medullary thyroid cancer, sir, because of the more aggressive nature of the disease, they have been classified as highest risk, high risk, and moderate risk. So highest risk corresponds to codon 918 mutation, which is seen in MEN2B. So here, the onset of the medullary thyroid carcinoma occurs within the first year of life. So prophylactic thyroidectomy preferably has to be done within 6 months of life, sir. Otherwise, there will be metastasis of the disease and the consequences leading to death. Whereas in high risk, it is codon 6.
Okay.
Yes.
Okay, I take that. Now you have done, it's a sporadic case. You have done a total thyroidectomy and central neck dissection and left side neck dissection. Pre-operative calcitonin was 120 in this case.
Yes.
So post-operatively, when you would like to have calcitonin estimation?
3 months, sir. 3 months.
Okay, why 3 months?
Because the half-life of calcitonin is longer, sir. So for it to reach its basal level, it would take 3 to 6 months is what they say. But the earliest we can do is 3 months.
Okay, accepted. So usually, customary it is that we do it at 3 months. Now, how do you follow these patients?
Yes, sir. These patients, so there is, these are followed, the cure is mentioned in terms of clinical cure, biochemical cure, as well as a loco-regional control of the disease, sir. So every 3 months, we have to do the calcitonin as well as the CEA levels, sir. So if these both the basal as well as then there's something called as stimulated calcitonin levels. So these are the stimulated calcitonin level measurement is more specific. So if the stimulated calcitonin level is less than 10 picogram per ml, then it is said to be within normal limits. So the patient can be followed up again after 3 months with the neck ultrasound and again calcitonin measuring times. And then one more factor that is considered is the doubling time of the calcitonin, which when it is less than 6 months, like if it was 40 initially and the 80 will be within like 6 months, then it is considered to be more aggressive. Whereas if it is greater than 24 months, then again we can have a relaxation in the period of follow-up for the patient in the form of neck ultrasounds.
Okay, okay, accepted. So there are two things. One is calcium doubling time. You have to see in the follow-up. What is calcitonin ratio? There are something in the literature regarding calcitonin ratio.
The ratio of the procalcitonin to calcitonin, sir?
No. So it is pre-operative calcitonin versus post-operative calcitonin, and this calcitonin post-operative has to be the first week calcitonin, 3 to 7 days. Urinary customarily we take calcitonin at 3 months after surgery, but calcitonin ratio is in the first week, and that ratio predicts whether you have done a complete surgery, there is biochemical or structural cure or not. That will predict. So people have tried to define a ratio, and by that ratio people have tried to define whether it is a complete cure or not.
Yes.
Okay. And then in the follow-up, calcitonin doubling time is important.
Yes.
Yeah. So tell me the prognostic features, prognostic factors for medullary thyroid cancer.
The size of the swelling, sir, and the presence of central compartment, and then the lateral compartment lymph nodes, which again, if it is only ipsilateral central, then it is a good prognosis, whereas ipsilateral lateral, contralateral central, and contralateral lateral indicate that the disease is progressing, and the calcitonin and the CEA level, which when very high, indicates that there is distant metastasis, sir.
Okay. So one thing you forget, whether it is a sporadic and familial, which one is more aggressive?
Sir, familial is more aggressive. MEN 2B is the most aggressive form of medullary thyroid carcinomas.
Okay, so MEN 2B, then sporadic, and then isolated medullary. Isolated familial cases are also there. Not non-MEN medullary cases. Okay.
Yes.
So that's the sequence. Yeah.
Yes.
So that is all from my side. Yeah.
Can we have Karnakaran sir and Madhu sir to give their closing comments so that we go on to the next case, please?
Sir, yes, sir. She has done well, sir. Almost everything has been covered, I think, sir. Okay. She has done well, sir.
Okay.
Of course, she has done so good, sir. She can pass through.
Okay. Dr. Meghna, do you have any doubts or comments so that you can get clarified with the senior faculty here?
No, sir.
Thank you, Dr. Meghna. Thank you, Guru Shantapa sir, for giving this PG for this case presentation.
Thank you, sir.
Anand Mishra sir, we have another case. It's an abdomen case. I would still
I'll be there.
you to stay with us, sir.
Yeah, please. I'll be there.
Thank you, sir. Thank you. Dr. Meghna, please unshare your screen. Thank you, Meghna. And on behalf of all the faculty, we wish you very best.
Thank you, sir.
I'm not sure whether you're going to take up endocrine surgery as your profession, but then definitely you have done very well. Very nice.
Thank you, sir.
Dr. Sweetie, can you try sharing your screen?
Yes, sir.
You please switch on your video, ma.
Yes.
Yep. And make it a full screen also. You can make it full screen and start. Yes, Kana, you are ready to go. Please. Good luck.
Good evening, respected teachers. Myself, Dr. Sweetie. I am JR3, Department of General Surgery, Institute of Medical Science, Banaras, Hindu University. I am presenting a case of abdominal lump under the moderation of Professor Ajay Khanna, sir. My head of the department is Professor Punit, sir, and my thesis guide is Professor Rahul Khanna, sir. Here is the case. A 34-year female resident of Balia, UP, housewife by occupation, presented in emergency department with a complaint of abdominal lump for 4 months and pain abdomen for last 10 days. History of present illness, as stated by patients, she was apparently asymptomatic 4 months back when she started developing a lump which was started in lower abdomen, insidious in onset, initially smaller in size, gradually progressive and attained the present size. And lump abdomen is associated with the abdominal heaviness. She also complained of pain abdomen for last 10 days, which was more in lower abdomen, insidious in onset, severe in intensity, continuous in nature, radiated to whole abdomen and groin. And pain abdomen is not associated with the perrectal bleed or pervaginal discharge. It is not associated with altered bowel habit. There is no aggravating factor. Pain is relieved after taking medication. She also had history of decreased appetite for last 1 month. In the form of it initially ate 4 chapatis in each diet. Now she ate only 2 chapatis. She also associate having complaint of generalized weakness. She had no history of fever, cough, hemoptysis, melena, urgency, increased frequency, burning micturition, and hematuria. She had no history of jaundice, back pain, hemoptysis, chest pain, headache, and significant weight loss. She had no history. She had no history of any comorbidities like diabetes mellitus or tuberculosis and hypertension, and she had no history of ATT intake or tubercular contact. She underwent total abdominal hysterectomy 6 months back for PV bleed. Personal history: she takes mixed diet, normal bowel bladder habits, sleep pattern normal, and she had no allergic to any known substances. She had 2 children, all delivered by normal vaginal delivery. Family history: she had no history of similar illness in any other family member. And treatment history: she took oral medication for pain abdomen. To summarize my history, 34-year-old female presented with lump in lower abdomen for 4 months, which was insidious in onset, gradually progressive, associated with pain abdomen and heaviness, associated with loss of appetite and generalized weakness, and she underwent for a total abdominal hysterectomy for 6 months back. Sir, I'm completing my history part.
Dr. Madhu sir, Dr. Anand sir, and Dr. Karnakaran sir.
Let her go ahead.
Come to first slide. So in abdomen, you should describe it as a mass per abdomen. So can you tell me the difference between a lump, a mass, and a swelling?
Sir, lump is a vague swelling present in the body tissue, while swelling
Example?
is like sir.
Breast lumps. Breast lumps.
Yes.
So you will call it as a lump in the breast there.
Yes, sir.
Whereas in my abdomen?
In swelling, sir.
No, it's not swelling. Swelling is different. Define swelling.
Swelling is a vague word which is used for defining any abdominal swelling arising from.
Swelling is swelling. Define swelling.
Swelling is a vague term which is used to define any abdominal swelling which was originate from the any particular region like congenital swelling or any traumatic swelling.
Which is visible like thyroid, hernias, lipomas. Those are all swellings.
Yes.
So this should describe as a mass per abdomen. Okay.
Okay, sir.
Come to next slide. Next slide.
Sorry. Sweetie, you said lower abdomen. Could you be more specific? Could you be more specific about which portion of the abdomen? Is it all below the umbilicus, the whole abdomen below the umbilicus, the lower half of the umbilicus, of the abdomen below the umbilicus?
Sir, she exactly had.
Is it in the hypogastrium?
Yes, sir. She had complaining of pain in the hypogastric region, which
So
is
you should mention in the pubic region, on the hypogastric, wherever it is. Just lower abdomen is very vague.
actually, yes, sir. It is in history part, so I.
Also, you can ask her where about.
Okay.
You are a doctor. You can interpret her words. You're supposed to put the history is in is your interpretation of what the patient has told you.
Okay, sir.
Right. So you can be more specific.
Okay, sir.
Right. And did you find out why did she undergo a total abdominal hysterectomy?
Yeah, so she complaining of, she told that she had complained of pervaginal bleed continuously for 1 month. So we underwent ultrasound sonography in which we made the diagnosis of uterine fibroid.
So it was a fibroid. Okay.
Yes.
Right, just go through your slides then, please.
Okay.
Okay, next. Fever, cough, urgency, urine. Okay, next. Okay, that's fine. So what do you think you're dealing with history? You can just summarize the history, please.
Okay, sir. 34-year-old female presented
Just
with
mass in the lower abdomen.
Sorry.
With pain.
Okay, sir. Mass
Nothing else.
abdomen and pain. Mass in lower abdomen and pain with 4-month duration of mass abdomen and pain for last 10 days and associated
Pain for
symptoms.
10 days.
Pain for 10 days, yes.
So, okay, so what do you think you're dealing with now?
So on the basis of history, my provisional diagnosis is a mesenteric cyst or mesenteric cyst or adnexal mass or ovarian.
The total abdominal, you can't have an adnexal mass now.
No, so
Okay.
only total abdominal hysterectomy, not salpingo for it.
Okay, so difficult to come to a diagnosis by your history.
Okay.
Very difficult to come to a diagnosis. Right? Should we go with the examination, please?
Okay, sir. Examination of patient done after taking informed consent in the presence of female chaperone with adequate exposure. Her VMI is 31.92 kilogram per meter square. Her Karnofsky performance score is 90 and ECOG score is 1. General physical examination. Patient was conscious, cooperative, well oriented to time, place, and person. Her vitals are temperature. Patient is afebrile, pulse 70 beats per minute. Blood pressure 110/76 millimeter of mercury in right time supine position. Respiratory rate is 16 per minute. Pallor, icterus, cyanosis, clubbing, pedal edema, lymphadenopathy were absent. Patient is adequately hydrated. Local examination. For abdominal examination, on inspection, abdomen is distended, umbilicus is centrally placed, all quadrant moving proportionately with respiration. There was an phalansteal incision scar with multiple striamas present over lower abdominal skin. No visible pulsation, peristalsis, venous engorgement seen over the abdomen. Hernial site intact. On palpation, local temperature was normal, abdomen was distended and mild tender, no guarding or rigidity. A mass of size 17 cross 15 centimeter is palpable in umbilical region involving right and left lumbar region and right iliac fossa and hypogastrium. A lump was globular shape, firm in consistency, smooth surface, all margin including lower margin were well defined, mobile side to side but restricted movement upward to down and not moving with respiration. On leg raising test, mass become less prominent and there was no other mass or organomegaly were felt in abdomen. On percussion, liver span was 12 centimeter. Percussion over the lump was dull and the resonant on side of the lump. No evidence of free fluid. On auscultation, a vowel sound was heard. No brew heard over the anywhere. On DRE, an anal tone normal. No growth present. No ballooning or no blood staining were present. Fecal staining present, and there was no mass felt in a digital rectal examination. On pervaginal examination, bilateral fornices are free and non-tender and no mass felt through the pervaginal examination. Spine examination were normal, renal angle were normal, no supraclavicular mass were felt. On systemic examination were within normal limit. Now summarizing my history, a 34-year-old female presented with mass in lower abdomen for 4 months, gradually progressive, associated with pain, abdomen and heaviness, history of loss of appetite and generalized weakness. She underwent total abdominal hysterectomy 6 months back. And on examination, there were a well-defined firm intraperitoneal lump of size 17 cross 15 centimeter in umbilical region, extending to right and left lumbar and the right iliac fossa and hypogastric region. All margins of the lump were well palpable and lump was mobile side to side. On the basis of my history and examination, my first provisional diagnosis is mesenteric cyst.
Okay. So you think it's a, sorry, go on, sir, please. Dr. Karunakaran, please go on.
You are saying it's mesenteric cyst, am I right?
Yes, yes sir.
Why don't it be an ovarian cyst?
Sir, because lower margin of the mass is well palpable, sir.
Lower margin is well palpable.
Yes.
Any other point?
And on pervaginal examination, there is no mass felt.
You can't find any mass in the pervaginal examination if the cyst is too big, that is 17 into 15 centimeters.
Yes.
If it is too small, we can do a pervaginal examination and find out some cyst. If it is too big, it may come out of the pelvis and it will occupy the abdominal cavity rather than the pelvic cavity.
But there was no any bulge, even no any bulge in the pervaginal examination over fornices.
Well, I am asking why you say it is a mesenteric cyst. What are the points in favor of mesenteric cyst?
Because it is a central abdominal mass with well-defined all the margins, and it mobiles side to side. That is along the attachment of the mesentery, but restricted movement on the perpendicular direction, and it is dull on percussion, and adjacent area of the mass were resonant on percussion.
So what is the attachment of mesentery?
Sir, mesentery were attached to the posterior wall of posterior abdominal wall to the second lumbar vertebra, left side of the second lumbar vertebra, and go downward towards the right iliac fossa and attached to the anterior part of the sacroiliac joint.
It should move perpendicular to the attachment of mesentery. Am I right or not? Is it moving in such a way, or it is moving left to right?
Move in left to right, horizontal direction.
That is, then it may be more in favor of an ovarian cyst. Am I right or not? Go ahead.
Yes.
Sweetie, Dr. Sweetie, you can tell her,
Yes,
tell us that you can say that because she's undergone TH.
Yes, sir.
So obviously the ovaries would be out, wouldn't
Yes.
it? So, yeah. Unless the history is absolutely wrong.
Yes, sir. There is no documentation of previous surgery, so.
You didn't have any documentation.
Yes.
So then it can still be, then it can be a large fibroid. It can be anything. It can be a large ovarian cyst also, which is gone into the abdomen now. Right? So we cannot. Those possibilities have to be kept there.
Yes.
Preeti.
Yes.
I mean, Sweetie. The point is, with this age of 35 years, they may not remember both the ovaries. Even if the patient undergoes a total abdominal hysterectomy, they may keep one ovary at least for the sake of.
Right, that's right. It could be just the oophorectomy may not have been done.
Not done. Not should be done.
Proceed now.
Sweetie.
Yes, sir.
How will you confirm whether it is a mesenteric cyst or ovarian cyst? Any test?
On the clinical examination.
Yes.
Yeah.
Sir, there is a teloxtride to which I confirm the my diagnosis as a mesenteric cyst.
What is that?
Any bedside examination?
Any examination test?
Ask her to
Some
stand up.
sign? Some sign?
Ask her to stand.
Uh,
So what happens to the swelling? Mass.
Sir, if there is any ovarian cyst, there is a pulsation over the.
No. If it is a ovarian, it falls to pelvis.
Yes, I want to.
So you won't be able to feel the lower border.
Yes.
So if it is mesenteric cyst, it doesn't fall
It
to the
yes,
pelvis.
sir.
So that is the
lower border
simple
is
test.
palpable.
Yeah.
And what is Tanoel sign?
Sorry, sir.
Tanoel sign on percussion?
Sir, on percussion, mass is dull on percussion, and surrounding areas of the mass is resonant due to
In what?
because of large mass is pushing the bowel towards the periphery.
Okay. Can go on now. How will you manage this patient now?
So to confirm my diagnosis, first we'll do ultrasonography of the abdomen and to see the cystic or solid nature of the mass. And after that, ultrasonography to delineation to better understanding to relationship with the other adjacent organ of the of mass with the other adjacent organ. We'll do CCT abdomen and confirm my diagnosis.
Is there any other slide?
Yeah. So on ultrasonography of the abdomen, sir, there was a large lobulated mass lesion, measures 23 cross 22 centimeter with internal necrosis area is noted, arising from the right adnexal region and extends up to the mid abdomen. And lesions is displacing the colon laterally and bladder anteriorly. And radiologist give the differentials as a mesenteric or adnexal mass.
Adnexal mass means it's an ovarian cyst or something else.
Cystic swelling, so arising from the right ovary.
And then automatically it is an ovarian cyst. Am I right, or am I leading on the wrong side?
Ovarian on ultrasonography, it is not confirmed whether it is arising from ovary or other adnexal structures. So we'll do a CCT abdomen.
Okay, go.
On CCT abdomen, suggestions are a large, relatively defined multiloculated, predominantly cystic lesions of approximately size 12 cross 18 cross 22.5 centimeter with multiple internal enhancing nodule and septi, thin to thick, is noted, possibly arising from the right ovary, and the lesion is causing posterior displacement of the bowel loop without evidence of obstruction. And the CT imaging features are more in favor of malignant right ovarian mass.
What are the points in favor of malignancy as per CT?
So on clinical examination, malignant ovarian mass, there is a irregular solid cystic heterogeneous consistency of the swelling and associated with ascites and or irregular border and patient having some constitutional symptoms like weight loss and
that and all is an advanced situation now.
yes, but on clinical examination there was no evidence of any malignant.
Yes. Your clinical examination and your investigation must be concordant.
Yes, sir.
Yeah. Go ahead. Other investigations?
And sir, to excluding the malignant ovarian mass, we will go with the biochemical investigation, and we'll do CA 125, which is comes within normal limits, sir.
Okay.
And
yes. Any other slides?
No, sir. Actually, patient is came 2 or 3 days before, sir.
Yes. Okay. SCA 125 normal.
Yes, sir, came normal.
What will you do next?
And
Is the patient is having ascites?
no, sir. Patient having no any symptoms of malignancy at
No ascites.
no ascites and no any lymph node and other mass palpable lump.
Node for this patient.
Yes, sir.
Any left supraclavicular node?
No, sir. I did mention, sir, no supraclavicular lymph node palpable.
Is there any relation between a supraclavicular node and this?
Yes,
left
sir.
supraclavicular node
And intra-abdominal malignancy will metastasize to the left supraclavicular.
What is the regional node for ovary?
It's a aortic and preaortic group of lymph nodes.
From there, it automatically goes to the left supraclavicular region.
Yes.
The regional node for testis as well as ovary is the para-aortic nodes. Okay.
Yes.
That's no supraclavicular node. So clinically, there is no point in favor of malignancy.
Yes.
The 50 findings are in favor of malignancy.
Yes, sir.
Okay. What will you do?
Sir, to confirm my diagnosis, we'll go with the exploration with the and to confirm the diagnosis with HP report.
Well, what kind of biopsy you do for HP?
Sir, we plan the actually in city and city CCT abdomen report, there is no local invasion of the local or distal, no distal, no any sign and symptoms of no any features of metastasis, and the mass is not invading the any adjacent structures. So we plan for excision of the cyst. So before any intervention, we would like to explore the patient and excise the cyst and send for HP.
Why don't you do a laparoscopic surgery for this patient? Why don't you put a scope inside, put a suction cannula inside, suck all the materials, then with the bag, can we remove it?
And so, sir, in this condition, chances of recurrence is more, sir.
Why? You are hitting the target.
Chances of metastasize to the port site and
see the actual staging of ovarian tumor is if the tumor spills out of the, if the tumor cell spills out of the cyst, any stage will get upstage to stage 4. That is, it will become a metastatic disease, spread all over the peritoneum. So you should not break the cyst. So it should be removed in toto if we suspect it is a malignant one.
Malignant, yes.
Or if it is a what are the types? You don't know about the ovarian mass as a surgeon, am I right?
Yes.
Okay. See, from the beginning, I was hitting around the ovarian cyst, am I right?
Yes, sir.
Yes. So this is very common. The commonest thing is you come across ovarian cyst very commonly rather than a mesenteric cyst.
Yes.
And we surgeons commonly think and we talk about mesenteric cyst. The common thing is ovarian cyst. The ovary commonly present in the abdominal cavity if it is huge, because the pelvis cannot hold that huge size ovarian cyst.
Yes, a large pedunculated ovarian cyst, lower border is easily.
Okay, you do a laparotomy, you remove the cyst entirely and send it for HP. Okay.
Yes.
Am I right?
Yes, sir.
If it comes as malignant, what is your treatment?
Sir, and then we're planning for chemotherapy.
Why chemotherapy?
To prevent the loco-regional metastasis.
Yes, it was within the peritoneal cavity. There may be peritoneal metastasis, so we can go for a chemotherapy. Okay.
Yes.
Am I right?
Yes, sir.
What is second laparotomy?
Sorry, sir.
Second laparotomy.
I don't know.
Don't know. See, as far as the ovarian malignancy is concerned,
Yes, sir.
debulking of the tumor is the most important mode of treatment. So you can give chemotherapy. If the tumor recurs, you can go for relaparotomy and debulk the tumor or remove the tumor completely, or remove the tumor as much as possible and go for chemo again. If it recurs, you can go for the third laparotomy also, if it is possible. Okay.
Yes, sir.
Okay, you have presented reasonably good.
Thank you, sir.
For other faculties, sir, please.
Yeah, I think if you are suspecting this patient as a malignant ovarian tumor,
Yes, sir.
so it is not only that you are going to just excise that. You have to carry out multiple biopsies. That is very important, and you have to look for if there is an ascitic fluid is there, you have to send it for the cytology. Even if there is no ascitic fluid is there, then you have to put the saline there and take that saline to see for the malignant cells. You may have to take a biopsy from the diaphragm. You have to take the biopsy from the pelvic peritoneum, which is there. Any lymph node suspected has to be taken for the biopsy. So a surgery for the malignant ovarian tumor, it is not just removal of the uterus and the ovaries. You have to do all these biopsies. Yeah, you have to carry out all those things.
Yes.
Sweetie, can you tell what are the various cystic tumors of the abdomen? Or cystic masses of the abdomen? Yeah.
Yes, sir. Cystic mass of the abdomen are first from the solid derived from the solid organ like liver, hydrated cyst, or spleen, hydrated cyst of the solid organ, and the mesentery and omentum, and ovarian cystic cyst, ovarian cystic swelling, sir, like serous cyst, mucinous cyst, and others. And
may I ask, Dr. Sweetie, there's a risk of malignancy index for ovary, RMI, where you calculate the risk for malignancy. Do you have an idea about it? It's called risk of malignancy index for CA ovary. You've got three things there. You have an ultrasound result which is scored, whether the patient is premenopausal or postmenopausal, that is scored, and it is multiplied by the level of CA 125 in international units per ml. And then you have a score where you calculate the risk of malignancy. So this is called an RMI, risk of malignancy index score for ovarian cancer.
Then you have on the Doppler study, you can predict whether it is a benign or malignant. And that is another scoring system which is there. And that is probably called as the Sassoon system, which is there, in which you are looking for, is it a tumor which has only the cystic element, or it has got the solid element? What is happening to the wall of that whether the wall is thickened or not, whether it is smooth wall or not, or whether it is nodular. Like in this patient, you have shown the enhancing nodules and septae are there. They are in favor of thin and thick septas. Yes. So they are more in favor of the malignant type of the tumor rather than the benign tumor. So you can also, based on that, you can decide, and then definitely you will look for the vascularity which is there, that how much is the vascularity in the wall itself or in the periphery or the other vessels which are there, that how much is the vascularity which is coming from the uterine artery and how much is the vascularity from the ovarian which is there. That is seen, and that also can decide whether it's a benign ovarian cyst or whether it is a. Yes. Pretty, what is cancer cachexia, which can occur in a case of ovarian tumor? What do you understand by that?
So cancer cachexia is defined as a significant weight loss due to cancer's pathology, sir.
What is that significant weight loss?
Significant weight loss, sir. decrease in 10 kg weight in 6 months, sir.
That you do not, that you just say that the patient is having this problem, but to define the cancer cachexia is if there is more than 25% weight loss of the original weight which is there. So if that is there, then that is defined as a cancer cachexia. You know, when we talk about the oncology, what is the old patient? What is the age of that patient?
So more than 60-year-old.
This patient.
Any oncology patient which is there, you know, the treatment depends upon that.
Yes, sir.
In fact, up to 60 years, they are relatively the
After
young
60.
patients. They are the young patients. 60 to 72 is the middle one.
Middle.
And if it is more than 72, because all the modalities which are there, they are changed on the basis of. So if you say somebody that it is a 58 years old patient, that is not correct. More than 72, which is there, is the for the oncological patients. Okay, 72 years.
Yes.
So you were telling about other cystic masses which are there.
Like so mesenteric cyst and the omental cyst and any solid organ cyst like hydrated cyst.
Can any retroperitoneal lumps present as a cystic mass?
Retroperitoneal cystic swellings, retroperitoneal sarcomas.
Pancreatic pseudocyst is there.
Yes, pancreatic pseudocyst.
Two cysts of the pancreas which are there. The patient is having a huge hydronephrosis, can present as a
cystic.
A big adrenal cyst can present as a cystic mass. Because these are the differential diagnosis which you have to give. Now, if you think it is a mesenteric cyst, what type of the mesenteric cyst it is?
Sir, most common type of mesenteric chylolymphatic type of mesenteric cyst, sir, which is most commonly occurred in the age group.
And what is the other one apart from the chylolymphatics?
Other one is the enterogenous mesenteric cyst, and then teratomatous mesenteric cyst, and urogenital type of mesenteric cyst, sir.
Now, what is the basic difference between a chylolymphatic cyst and an enterogenous cyst?
Sir, a chylolymphatic cyst is derived from is a thin wall structures, while enterogenous cyst is a thick structures. Chylolymphatic cyst having different blood supply from the mesentery, while intestine, while the enterogenous cyst having the same blood supply as the intestine, and so in the management part of the chylolymphatic cyst, only enucleation is the sufficient, while in enterogenous cyst we excise the cyst along with the bowel segment in which is present. So.
Very good. Good. Yeah. Yeah. Okay.
Madhu sir, you would like to ask something, sir? Professor Madhu sir?
Sweetie.
Yes, sir.
What is pseudomesenteric cyst?
So pseudomesenteric cyst in case of tubercular of mesentery, tubercular lymphadenitis get infected and ruptured inside the mesentery, and the pus collected in the two lips of the mesentery and form a cystic swelling.
Cold abscess, like a cold abscess.
Yes. Yes.
Mimics mesenteric cyst.
Yes.
Okay. Okay, sir.
One last question.
Yes, sir. Most welcome, sir. Yes, sir.
What is Meeks syndrome?
So Meeks syndrome is a ovarian tumor with ascites and pleural effusion.
Is it a benign tumor or malignant tumor?
Also, it is a malignant.
No, it is not malignant tumor. What is the type of the histology in the Meeks syndrome?
So, epithelial, sir.
It's a fibroma of the ovary.
Epithelial tumors of fibromas.
Yeah.
Fibroma.
And
Solid
usually,
tumors.
Yeah, it may present with a huge lump in the abdomen with a pleural effusion, but somehow these tumors are not probably malignant. They are probably benign tumors here. What is the characteristic of a Krukenberg tumor?
So Krukenberg tumor is a secondary tumor of the ovary, which is metastasized from the different GI and breast tumor, and it is a large and it present in most commonly premenopausal women, and it is a large enough and heterogeneous in consistencies, a solid cystic type of.
Most of the time they are solid tumors. No? Is it unilateral or bilateral?
So Krukenberg tumors are not so suicide.
They are mostly bilateral. Okay, because the transcoelomic spread which is there in a premenopausal female patient.
Yes.
When the ovaries every month they rupture, they leave a raw area there, and the malignant cells they get deposited on that.
Yes.
Most of the time it is in the premenopausal.
Yes.
And they are usually bilateral. So bilateral solid tumors are the Krukenberg tumors here. Apart from the breast, from where they can come?
Sir, hereditary non-polyposis colorectal cancer in Lynch syndrome.
Which Lynch? 1 or 2?
Sir.
Most common is gastric carcinomas.
Yes.
Right, gastric carcinoma.
Colonic cancers are in the Lynch 1. No? Right. You know any chemotherapy which is given for the malignant ovarian tumors?
Yes, sir. Platinum-based and the taxane-based chemotherapy. In platinum-based, we can use a cisplatin or carboplatin, while in taxane-based or paclitaxel or docetaxel, we can use.
What is the toxicity of cisplatin?
Sorry, sir?
What is the toxicity of the cisplatin?
Toxicity of immunosuppressant, myelosuppressants.
The specific toxicity for cisplatins or any platins rather than a general toxicity.
Not remember, sir.
It is mainly the nephrotoxicity. Okay, renal toxicity
Yes.
which is there. So that is why you have to very properly hydrate this patient before you give the patient the
Toast.
You know what is the tumor lysis syndrome?
Yes, sir.
Which
Large
can occur
malignant.
after this chemotherapy.
Yes, sir. After giving a solid, in case it is more common in solid tumors like ovarian or lymphomas or testicular germ cell tumors. After giving a chemotherapy, tumor cells lysed and it will cause the hypercalcemias and
So what you should do for the tumor lysis syndrome? How should you prevent it and what is the treatment for that?
Allopurinol were given.
Because there is hyperuricemia.
Hyperuricemia is there, sir.
So you can give the patient allopurinol, but the most important is the proper hydration. Okay, to prevent as well as the treatment for that is to have a very proper hydration, and then you can try certain these drugs like the allopurinol can be tried for that. Yeah. If a patient is a young patient, has got a ovarian cancer, young patient who has not completed her family,
Yes.
what are the options?
Sir, we can go for chemotherapies.
No, she has not completed her family and she wants to have her own babies. And if you give the patient chemotherapy, what can happen? Like in a case of testicular tumor, if you want to, patient says that I am still not married or I am married but I don't have a children.
We ask for patient for semen preservations.
I'm not entirely sure we have a chapter for this now. I'll see if we can find it.
Thank you.
Can we do something in the females also?
A lot of people are getting it done these days without any malignancies because of increasing age. They want to have a baby later on. Egg preservation.
Egg preservation.
Right. Generally, these kind of tumors are dysgerminomas. Germinomas are seen in young women and bilateral ovaries. So this is where you have to do this. You can save.
You do the cryopreservation of the
eggs,
or you freeze the embryos or the ovas which are there, you freeze that. Okay. So if it is a unilateral ovarian tumor is there and if it's a bilateral ovarian tumor is there in a young female, what are the options?
Sir, in bilateral ovarian tumors, we can go with in young women, we can go with the egg preservation, and after that we manage the patient with the surgery and then chemotherapy. And if patient having unilateral ovarian tumor, then we'll go with surgery and then chemotherapy without these preservation.
What you will do to the ovary, to the uterus? So if you are removing both the ovaries, then you will always remove the uterus.
Total abdominal hysterectomy with the bilateral self-ing oophorectomy in case of bilateral ovarian tumor.
So has your patient undergone the total abdominal hysterectomy or she has undergone the panhysterectomy? What is the difference between these two words? Panhysterectomy and the total abdominal hysterectomy?
So in panhysterectomy, we will remove the cervical and the adjacent lymph nodes structures.
No, not talking the radical. We are talking the panhysterectomy. Okay, when we are doing the total abdominal hysterectomy, we are removing only the uterus, but we are leaving both the adnexa. So both the ovaries and the tubes are left over. Some people they remove the tubes, but ovaries has to be present on both sides. Panhysterectomy means that you are doing a hysterectomy plus bilateral self-ing oophorectomy. So probably this patient has undergone only the total abdominal hysterectomy and not a self-ing oophorectomy, and that is why probably she has come out with the tumor of the one of the
Ovaries.
Ovaries which are there. So is it a preferable option, pan-hysterectomy nowadays?
No,
When
sir.
somebody has got a DUB, dysfunction
Yes, sir.
uterine bleeding.
Yes.
So will you do a pan-hysterectomy in that patient or not?
Pan-hysterectomy, sir, is nowadays not recommended, sir.
So you have to always preserve every tissue of the ovary. Okay.
Yes.
So as far as possible from the various problems which can occur after removal of the ovaries, all post-menopausal symptoms which are there. So, and there are a lot, there can be heart problems may be there, there can be the various types of the problems may be there if you remove both the ovaries. So that is why you have to preserve every part of the ovary to prevent all these problems. And that is why if the uterine problem is there, you will not carry out the pan-hysterectomy. You just do a simple total abdominal hysterectomy. Right. Dr. Kanayal, can we close it now?
Yes, sir. Sir, any other input or any questions from Dr. Sweetie to the faculty?
Yes, sir. I have a query, sir.
Yes,
Actually,
yes.
patient having no any clinical symptoms like malignant features. So how to manage the patient, sir?
No, but you are telling the patient the weight loss, isn't? Weight loss is there?
No,
Ovarian,
sir. No, sir.
ovarian
No weight loss.
cancers are known as silent killers because they're detected very late.
Actually, patient having no any other lump and ascites and the weight loss or any malignant features.
Right.
So how
Ovarian
can
cancers are known to present this way. Just a gentle, slow increase in abdominal girth. That's why they're known as silent killers. By the time they're detected, it's too late.
Yes,
right.
So
So you have to keep that in mind.
that's why, sir, we kept the first diagnosis as a mesenteric because patient having no any
Hi, sir, you're in mute mode, sir.
A
Yes,
lady with ascites or lump with a vague lump in the abdomen, in the lower abdomen, you have to think of ovarian malignancy until approved otherwise. Right? It's always that way.
Thank you, sir.
And thank you, faculty. Thank you, PGs, for joining us today. Next week, we have Friday. We have a portal hypertension case contributed by Dr. Rajan Patel, sir. And we will be taking one more case, possibly a oral cancer or one of the oral malignancies. If any of the faculty or any of the resident want to present a case on oral cancer, we will have it in the coming week. Kanna sir, you like to add anything to this, sir?
It's okay, absolutely fine. Yeah.
Yes, sir. Yes, sir.
Yeah.
And I thank Karnakaran sir from Sivagangai, Madhu sir from Mysore, and Anand Mishra sir from Lucknow for joining today's program. I think we have Vivek sir and Guru Shantapa sir, and I think we could see Dr. Jeevan Kumar sir also. Thank you for joining us. Madhu sir, you like to give any closing comments, sir?
Sir, no, sir. Everything is fine, sir. It was a nice to join you, sir. It's the first
Thank
time.
you, sir. Thank you.
Everything
No,
is
sir.
nice.
We'll be happy if your PGs also join us to present.
Yeah. I'll make them to present, sir. Next
yes,
time.
Sir. Yes, sir. Yes, sir.
I will contact you, sir.
Most welcome, sir. Most welcome.
Okay, sir.
Thank you very much, Dr. Kanigavel, sir. It is Dr. Jeevan Kumar here.
Please switch on your video, sir. I'll be happy to see you on video. Thank you, sir. Thank you, sir. Thank you so much, sir.
I am finding it very useful for medical gastroenterologists also because your standard of discussion is very good. Very high.
Thank you, sir. Thank you, sir. And I could see Ambujam madam and other seniors. Thank you, one and all. Thank you, faculty. We look forward for next class on coming Friday. Thank you, Sahai sir. Thank you, all the senior faculty here. Thank you, dear residents. We sign off for the day. Good night.
Thank you, sir.